Welcome to Mount Sinai. Welcome to this very important summit. It's really, really good to have you all here. One of the things that really struck me, I was looking through the book and also reviewing the slides that Maida and Amisha showed in the last few minutes, and a deep thanks to both of you and to your whole team for having put this thing together. I was really struck by the extraordinary diversity of backgrounds, agencies, organizations, individuals who are represented in the room here today. I'm probably missing a few. It's always dangerous to go over lists, but we've got people here from agencies of Health and Human Services, EPA and HUD on the federal level, New York State, State of New Jersey, City of New York, Commonwealth of Puerto Rico. I don't know if we have anybody here from the Virgin Islands, but I was there yesterday helping to set up a satellite children's environmental health program, so that sort of semi-counts. We have people from community-based organizations. We have health planners. We have people from a number of the medical schools and academic health institutions in the New York area, not just New York City, but across the state, all the way to Western New York, as well as New Jersey. So it's just amazing. It speaks to the importance and the widespread nature of the problem of childhood asthma in our region, that all of us have come together from so many places. So I want to make a couple of quick points to introduce the morning, and then we'll bring up the panel. The first point I'd like to make is something that you already know, but it's worth saying it really bluntly. That is that asthma is epidemic in our region. Asthma is an epidemic. Any disease that affects between 10 and 15% of children, and more in some neighborhoods like East Harlem, is epidemic. It's nothing short of that. If this were cancer, if this were Ebola, we'd be running for the rafters. It's just that asthma has been with us for so long that we've become hardened to it. Not entirely, of course, but to some extent used to it. We think of it as business as usual. We really shouldn't. We should treat asthma in our region as an epidemic. The second really important point is that research conducted here at Montefiore, across the United States and even globally, has identified a whole series of environmental triggers for asthma. We know with a high degree of certainty that a whole list of factors in the indoor environment as well as outdoor air pollution are triggers for asthma. We know that these environmental factors can initiate new cases of asthma. That finding came out very clearly from research that was conducted at the University of Southern California, where they found that there was a higher incidence of new cases of asthma in more polluted regions of LA than in less polluted regions. And we all know, it's our daily experience, that these triggers can provoke acute attacks in children and adults as well who already have asthma. So the research has been very fruitful, and it's given us a long list of triggers. You all know them. I won't go over them here, that are causes and triggers of asthma. And the third thing that we know with a high degree of certainty is that science-based intervention, which takes that knowledge about triggers, works. We know that if we go after air pollution, we know if we clean up apartments, get rid of mold, mildew, cockroach droppings, that we can reduce rates of asthma. One of my favorite stories is what happened in 1996 in Atlanta during the Summer Olympic Games. The mayor of Atlanta urged the citizens of the city not to drive for those 2 weeks of the games that summer, but instead to take public transportation. Atlantans are not like New Yorkers, I know, because I lived there for 9 years. They're obedient. And they actually did that. The air got cleaner. The athletes, of course, performed brilliantly. An unexpected byproduct was that hospital admissions and ER visits for asthma and respiratory conditions went right down, stayed down for 2 weeks, and then rebounded. General Motors had an explanation. They said people were trapped in their homes because the mayor wouldn't allow them to drive. Well, you know, that's nice, except for the data. And the data showed that GI disorders, orthopedic conditions, pretty much anything else that brings people to hospital stayed steady. Only respiratory and asthma went down and then rebounded. So we know that air pollution causes asthma. We know that going after air pollution outdoors, going after air pollution indoors can control asthma. So we have an epidemic, We know the causes. We know how to go after it. What's wrong with this picture? Why in the hell is asthma still continuing in New York, in New Jersey, in USVI, in Puerto Rico, if we have these three fundamental facts well in hand? And the answer is that we have not made it a sufficiently high priority, which translates in political terms to the fact that we have not put sustainable, constant, steady, sufficient year-to-year funding into the issue. Here at Sinai, we have a little federally funded entity called a Pediatric Environmental Health Specialty Unit. Maida Galvez and Perry Sheffield run it. It's a brilliant concept. There are 10 of them across the country, as well as others in other nations. But with 3 or 4 people and $200,000 a year, we're supposed to cover 2 states and 2 territories, or a commonwealth and a territory. It's a drop in the bucket, and it's a little here and it's a little there. And I salute the people who had the wisdom and the foresight to put this conference together today, because we really have to think about how we can make the prevention of childhood asthma, not the treatment, but the prevention of childhood asthma, a regional and a national priority. Thank you.